Hello, everyone. Welcome back to Simple Med Talks. Today, we'll delve into a topic that's crucial to understand: priapism. This medical condition involves prolonged and often painful erections. Let's explore the causes, mechanism, and management of priapism. But before we begin, if you find this content helpful, don't forget to hit that subscribe button and ring the notification bell so you never miss our medical insights. Firstly, let's clarify what priapism is. Priapism describes a persistent erection arising from dysfunction of the mechanisms regulating penile tumescence and flexidity. The erection of priapism is typically not the result of sexual excitement and, if associated with erotic stimulation, lasts well beyond the original stimulus and is not relieved by orgasm or ejaculation. A diagnosis of priapism is a matter of urgency requiring identification of the underlying etiology because prompt therapy may successfully alleviate the condition and minimize potential morbidities. It's essential to recognize that there are two main types: ischemic and non-ischemic priapism. The causes and management strategies can differ significantly between these two types. Now, let's explore the causes. Ischemic or low-flow priapism accounts for more than 95% of all priapism episodes. Ischemic priapism is typically associated with a rigid and painful erection with stasis of blood, and which is not relieved by ejaculation or orgasm. Sickle cell disease and other hematologic abnormalities are most often associated with low-flow priapism. Various drugs may precipitate an episode of ischemic priapism, such as trazodone, antihypertensive agents, alcohol, marijuana, cocaine, as well as intracavernous vasoactive agents such as papaverine, prostaglandin E1, phentolamine and others. Physical examination typically reveals painful or tender complete rigidity of the corpus cavernosa, sparing the glands and spongiosum. Abdominal and genital examination may reveal evidence of prior trauma or malignancy. Laboratory evaluation, including complete blood count and white blood count, to rule out infection and hematologic abnormalities, respiratory counts, hemoglobin electrophoresis when indicated, drug screening, e.g. cocaine and its metabolites, corporal blood gas testing, and duplex ultrasound if available should be performed. Non-ischemic or high-flow arterial priapism is a form of priapism typically caused by traumatic cavernosal artery laceration, or injury that enables unregulated flow of arterial blood directly into the lacunar spaces of the corpora, bypassing the protective, high-resistance helicin arterioles. This constant unregulated flow results in the pathognomonic arterial lacunar fistula of high-flow priapism. The clinical characteristics of non-ischemic priapism typically include a premorbid history of trauma, delayed onset of priapism following the trauma, incomplete rigidity of the phallus compared to premorbid sexually stimulated erectile rigidity, and a constant erection that is painless, non-tender, of persistent partial rigidity throughout the day and night with the potential for increase to full rigidity with sexual stimulation. Although spontaneous resolution may occur, with non-ischemic priapism the painless, partial erection will often continue unless active intervention is performed. Now, let's discuss the management of priapism. The approach varies depending on the type and underlying cause. Ischemic priapism may require drainage procedures or medications to reduce blood flow, while non-ischemic priapism might resolve spontaneously but could need intervention if persistent. In general, immediate surgical intervention should be avoided while less invasive and often successful alternatives are first attempted, especially in cases of less than 6 hours duration. Previous recommendations for priapism episodes associated with sickle cell disease included prolonged treatments with oxygen analgesics and intravenous hydration, prior to intracorporeal therapy or surgical intervention, due to the often repetitive and self-limiting nature of their priapism episodes. Unfortunately, this regimen is often unsuccessful and results in an increased rate of corporal fibrosis and erectile dysfunction, and is no longer recommended. In very select cases of priapism associated with sickle cell disease, the successful use of exchange transfusions to reduce the fraction of abnormal HbS hemoglobin, and hypertransfusion with packed red blood cells to double the hematocrit and diminish the fraction of HbS present has been described to achieve detumescence. Early hemoglobin electrophoresis to determine the fractional percentage of HbS present serves as a useful guideline for monitoring subsequent transfusion therapy. As with any transfusion of blood or blood products, the associated risks, including disease, transmission and HIV, should be discussed with the patients prior to transfusion, and the potential benefits weighed against the disadvantages. The AUA Guidelines Committee recommends the use of phenylephrine, an alpha-selective adrenergic agonist with no indirect neurotransmitter-releasing action. This agent minimizes the risk of cardiovascular side effects that are more commonly seen with other sympathomimetic agents. For intracavernosal use in adult patients, phenylephrine is diluted with normal saline to a concentration of 100 to 500 g/ml. 1 ml injections are made every 5 minutes as needed, up to 1 hour. During treatment, patients should be observed for SYMP-TOMS, such as acute hypertension, headache, reflex bradycardia, tachycardia, palpitations, and cardiac arrhythmia. For children or those with severe cardiovascular disease, lower doses are recommended. In patients with severe cardiovascular disease, it is prudent to monitor blood pressure and pulse rate in a controlled surveillance setting. The use of oral terbutaline, a beta agonist, both for the preventive and active treatment of ischemic priapism, has been suggested. Associated issues of ischemic priapism are 1. Persistence and recurrence despite active intervention. 2. Erectile dysfunction. It is estimated that more than 25% of patients with priapism will have some degree of ED. Selective internal pudendal arteriography has been the mainstay of diagnostic and therapeutic maneuvers for arterial priapism. The pathognomonic arteriographic finding is of an arterial lacunar fistula, a characteristic intracavernosal cone-shaped blush of contrast at the site of the cavernosal artery laceration. Unfortunately, these therapies have had little success in reversing the high-flow priapism state and are currently not recommended by the AUA guidelines for priapism therapy. The current standard of intervention remains selective internal pudendal arteriography with transcatheter autologous clot embolization. The goal of this therapy is to induce temporary occlusion of the cavernosal artery in order to allow the injured site to heal. The temporary nature of this occlusion allows for the subsequent re-establishment of physiologically controlled normal cavernosal blood flow, with preservation of erectile tissue viability and normal, long-term erectile function. This form of minimally invasive intervention has a high probability for resolution of the priapism with restoration of erectile potency compared to more invasive techniques, including permanent coil embolization and surgical ligation of the cavernosal artery. Studies comparing perineal duplex ultrasound and concomitantly preformed selective internal pudendal arteriography have revealed excellent sensitivity in detecting the arterial lacunar fistula that is seen angiographically on ultrasound. In both the selective internal pudendal arteriogram (PHY) and perineal duplex study, the arterial lacunar fistula was noted at the same location. In fact, in one reported case where physical examination suggested incomplete return to flaccidity and post-embolization due to recurrent fistula, the negative eperineal duplex Doppler ultrasound study correctly predicted the final clinical outcome of complete priapism resolution and full erectile function. Therefore, if the follow-up clinical examination is equivocal for recurrence of the arterial lacunar fistula, perineal duplex Doppler ultrasound may better predict the need for repeat arteriography and embolization. Wrapping up our discussion on priapism, it's crucial to seek medical attention promptly if you or someone you know experiences prolonged erections. Early diagnosis and proper management play a key role in preventing complications. If you found this information valuable, give us a thumbs up and share your thoughts in the comments below. Until next time, stay informed and stay healthy.